Morning, everyone. Welcome to our second of two CROI report backs. We were just hearing from our first presenter, Dr. Abelman, about the various forms of art that may or may not be controversial in Denver, featured on her slide. We're really lucky to have two presenters. I'm going to introduce them really briefly so we get to their fantastic presentations. Dr. Rebecca Abelman is Assistant Professor of Medicine in UCSF's Division of Infectious Diseases at the San Francisco VA. Her research is focused on sex differences in aging-related comorbidities in people living with HIV and the role of menopause in clinical outcomes in women living with HIV. She'll review work at CROI that was related to HIV and comorbidities. And then following this, Dr. Michael Peluso who is an Assistant Professor of Medicine in UCSF's Division of HIV/ID and Global Medicine here at SFGH, where he investigates the disruption of the HIV reservoir for purposes of HIV remission and is really a leader in the long COVID world. We'll hear from him about HIV cure research as pertinent to clinicians. And both of them really spent an exceeding amount of time on this talk, and I'm very grateful for their report backs. We will start with you, Rebecca, and as always, feel free to put questions in the Q&A, and we'll try to take some questions in between if we have time. If not, we'll move on to Michael, but we'll take it as it goes. Thanks so much.
Just trying to get my notes organized here. So thank you so much for inviting me to speak and to talk on one of my favorite topics, which is HIV and comorbidities. And we had a really, really great CROI this year. So excited to talk about some of the studies that came out of CROI. So I do have some institutional support from Merck. And today I'm going to talk about cardiovascular disease and statin use. Then I'm going to touch on GLP-1 agonists, on weight loss, sarcopenia, and then MASLD, which I will also update the new terminology for the group. And then at the end, I will touch on just a smattering of studies that I thought were interesting, touching on a variety of different comorbidities, including more MASLD studies, prostate cancer, lung function, and weight. The other thing I'd just like to say is that due to time, and because of the clinical focus of this grand rounds, I'm really going to be focusing on clinical studies. So I'm not going to, unfortunately, as much as there was a lot of really amazing translational and basic science work, I'm not going to be able to touch on that today. And then I focused mostly on domestic studies, although there were some amazing studies that were coming out of our own search team and others. So first, I'm going to talk about statins. And as a reminder for the group, so this was not presented at CROI this year, but was at IAS in 2023, and then later published in the New England Journal of Medicine. This is the REPRIEVE trial, and it was a randomized prospective trial of people with HIV who had low to moderate ASCVD risk. And they were receiving pitavastatin or statin versus placebo. And what they found was that it reduced MACE, or major adverse cardiac events, which include cardiovascular death, stroke, and myocardial infarction in the pitavastatin arm versus the placebo. So that's what you can see here in the figure on the right. And so what they found was that the event rates increased with increasing risk categories for ASCVD and suggested greater benefit among participants with a higher CV risk at baseline. So there was increased benefit in people who had a higher ASCVD risk. So as a result of that, moderate intensity statins are now recommended for most people with HIV over age 40. So these are relatively new guidelines coming out of the AHA, the ACC, HIVMA, and DHS. And so now for people with HIV who have low to intermediate 10-year ASCVD risk estimates, for people who are between ages 40 and 75 with a risk score between 5 and 20%, at least moderate intensity statin therapy is recommended, and this is a higher quality of evidence, A1. And then when the estimates are less than 5%, the panel favors initiating at least a moderate intensity statin therapy, although that's a lower quality of evidence. And then there was insufficient data for people with HIV under age of 40. And the other thing I want to highlight is that this is actually in line with what's recommended at Ward 86. So the current guidelines are that the recommendations of Ward 86 are that if the ASCVD risk scores greater than 5%, that we're starting a statin in our patients, and then if less than 5%, a case-by-case basis. However, in light of these guidelines and in light of the REPRIEVE results, this does have the remaining knowledge gap of if we can use ASCVD risk estimates to determine who should be on a statin. So this abstract was in an effort to address this question. So it was looking at the ACCH, a pooled cohort equation for risk prevention, and this was using the global reprieve trial. So the investigators wanted to see how well the pooled cohort equation, or PCE, measured cardiovascular risk among people with HIV in the reprieve trial. So what they did is they looked at those who did not receive a statin, so those in the placebo group, and they calculated the PCE for those individuals. And then they saw that how many of them had these adverse cardiovascular outcomes, including cardiovascular death, myocardial infarction, and stroke. And then they calculated the calibration of the pooled cohort equation to cardiovascular outcomes. And just as a reminder, the reprieve trial was a global trial, so it included people who were in high-income countries as well as in other countries around the world. So this is just from the table 1 from the New England Journal paper, just showing the breakdown of countries. And what they found, interestingly, was that, and these are just like the general demographics. So the mean age was 50 years, it was 31% female, 65% non-white, and then the average PCE risk score was 4.5%. And they found that overall the PCE discrimination was moderate, but that there were some key groups that it's worth noting that the PCE score was not accurate. So first, it overpredicted risk outside of the high income regions, which I thought was interesting, and then restricted to high income regions, under prediction occurred in some key groups. So the first was natal females, so the 2.56. So that means that women were 2.5 times, they had 2.5 times more events than was predicted with their PCE risk score. And then African American or Black participants had 1.66, so it's about 50% more events than their PCE risk score predicted. So I think one of the takeaways from this abstract was that we need to consider using different cutoffs versus if we need a completely different risk score for people with HIV. So moving on to another abstract that was also based in the reprieve data. So this is looking at pitavastatin and its effect on long-term objective physical function in the reprieve trial. So one of the hypotheses that the investigators had was that because of the anti-inflammatory properties of statins, that being on statins over the course of the reprieve trial would actually improve physical function or blunt physical function decline over time. So what they did over the course of the reprieve trial was that they looked at physical function metrics across the 5 years, and they had a variety of physical function tests, including grip strength and I believe gait speed. And what they found was that there was actually, while there were small declines in physical function in both treatment groups, there were no differences by statin use. So that's what you can see in the figure on the right, is that looking at the chair rise, gait speed, and grip strength, that there were no differences between the two groups. So in summary, the PCE may be underestimating risk for certain groups, so including natal females and Black or African American patients. Statins do not appear to improve physical function in people with HIV. And I think that this is particularly interesting, and I wanted to highlight Dr. Shu's session, which was in the Follow Your Heart Symposium, which was on Wednesday. And she did a really nice job outlining all of this data. But thinking about the results of the reprieve trial and thinking about this idea of the HIV inflammation hypothesis and whether or not statins are improving the inflammation, and that's partly what's improving some of the cardiovascular outcomes, that there's been some actually equivocal data that's been coming out both at CROI and then around the same time as CROI. So first is this article that was published in JAMA, I think actually during CROI, that was based out of the reprieve trial that was looking at statins and the reductions in inflammatory biomarkers. And they found that while statins had a reduction in the LDL-C, that they didn't see the same reductions in inflammatory biomarkers, including CRP, IL-6, SED163, and SED14. And then there was another abstract that was a sub-study within their reprieve trial that was looking at the proteomic data. And they found that actually in both groups, looking at the statin group, that didn't actually improve the inflammatory pathways in the proteomics sub-study. So I think that that's actually in line with what we found with the statin data as well. So now moving on to GLP-1 agonists. So GLP-1 agonists have a complicated mechanism of action. And as many of you will remember, they're an incretin hormone that's released after the ingestion of a meal. And it stimulates glucose-dependent insulin release from pancreatic cells and slows gastric emptying and regulates postprandial glucose, and has been found to reduce A1C, improve weight loss, and reduce CVD in patients with existing ASCVD. But what do we know about semaglutide in people with HIV? The answer is not a lot as of now. So there was an important abstract that came out of ID Week that I know Dr. Appa presented by McCompsey et al. And they were looking at people with HIV who had a BMI greater than or equal to 25, or an elevated waist circumference or an elevated waist to hip ratio. And those participants received semaglutide for 32 weeks. And then they used CT to measure visceral adipose tissue, and they also had DEXA scans. And they found that while people with HIV lost weight, so including visceral adipose tissue, subcutaneous adipose tissue, and lymph fat, they also experienced lean mass loss, which is in line with the results from both the general population as well as when people lose large amounts of weight more generally. But this was something that put lean mass loss on the radar for a lot of people in the HIV world. So there was quite a bit of work that was presented at CROI on the use of semaglutide in people with HIV. I'm going to briefly highlight this abstract that was looking at semaglutide on weight change in people with HIV, and they were looking at changes by baseline BMI. So this was within the CNIX cohort, and it was across 1 year of follow-up. And they found that participants lost on average 5% of their body weight, which was about 6.5 kilos. And then they found that the greatest weight loss occurred in those who had the highest weight at baseline. And then I just thought that this was an impressive figure showing the adjusted body weight that happened with time on semaglutide. So that corroborates some of the findings that were found in McCompsey et al.'s ID Week abstract, but then what happens with muscle structure and function? So this was a sub-study that was out of the Slim Liver study, which I'll also chat and show some of the results about. But this was a group that was doing a sub-study within Slim Liver, and they were really interested to see if there were changes in muscle quality and function, given the sarcopenia that was seen in the prior work seen with semaglutide use. So what they did was the Slim Liver study, which had cross-sectional imaging for all their participants, they wanted to see what happened to psoas muscle volume and psoas fat percentage because they had MRIs. And then they also had physical function. And what they found was that psoas muscle volume declined, but muscle fat content did not change significantly, which is what you can see in the figure on the right. And overall physical function was preserved so that these radiographic findings actually did not correspond to any declines in physical function. However, this was a limited amount of follow-up. And I think the other important point to mention is that people with HIV over 60 had the greatest decline in muscle volume, which is something that I think we need to keep in mind when we're giving semaglutide to our older patients. So now I'm going to move on to MASLD. And this is new terminology, so I'm going to spend a few minutes going over it, but now it stands for metabolic dysfunction associated with steatotic liver disease. So it's no more NASH, it's kind of a replacement of NASH. These are the new guidelines and how they are subclassifying steatotic liver disease. And as you can see on the far left, that this is MASLD as the metabolic dysfunction associated steatotic liver disease, which is separate from MET-ALD, which is MASLD and increased alcohol intake. So this study, the Slim Liver study, was looking at MASLD outcomes. So this is the Slim Liver study, and it was one of the most highly publicized and exciting studies coming out of CROI this year. And what the objective of this study was to determine the effect of semaglutide on MASLD, and they used imaging to look at these changes over time. So this was using MRI-PDFF, which is a type of MRI. And what they did was they enrolled adults with central adiposity, insulin resistance, or prediabetes, and then steatotic liver disease, which was defined using MRI-PDFF. And then they had participants who received semaglutide for 24 weeks and then had MRI-PDFF to measure intrahepatic triglyceride content at the end. So what did they find? So the participants, of which there were 49, had an overall median age of 52 years. Their median BMI was 35. 43% were cis or trans women, and then 82% were on an INSTI-containing regimen. The figure on the right is not from Slim Liver, it's from another paper that I cited below, but I just wanted to show what an MRI-PDFF looked like. So A is no fibrosis, and then you can see that fibrosis increases from BC to D, and D is the most extreme type of fibrosis, so that's what they were looking at. And the mean absolute IHTG decline was 4.2%. And then what was really exciting was that 29% had complete resolution of MASLD and 58% had greater than 30% reduction in the IHTG. And there were some, so this study wasn't powered to look at subgroups, but there were greater IHTG reductions in women and Hispanic and non-Hispanic white patients, and then also people who were over age of 60. The other thing that's worth noting is that this had significant improvements in metabolic parameters. So in summary, people with HIV lose weight with GLP-1 agonists, consistent with what happens in the general population. Sarcopenia is seen with use, but the clinical significance warrants further study. It seems like age is an important factor, so I think that's something that's worth keeping in mind when we are prescribing these medications for our patients. And that reversal of MASLD was seen with semaglutide use in people with HIV, and that was concomitant with other metabolic metrics. But are GLP-1 agonists the future of MASLD treatment? I think the answer is maybe. In the general population, as many of you already know, in people without HIV with NASH/MASLD, treatment with semaglutide had a significantly higher percentage of MASLD resolution, so 40 to 50% than placebo. This was in the New England Journal. But in a phase 2 trial, semaglutide did not significantly improve fibrosis versus placebo. So that's one of the major outcomes that we want to look at when we're thinking about improvements with these medications. There are new drugs on the horizon that, of course, have not been yet tested in people with HIV. One of them is this thyroid beta hormone agonist, and I don't know why that works with MASLD, but it's had very exciting results, both in improving MASLD resolution, but also significantly reducing fibrosis. There's several other just MASLD specific drugs. And then of course, there's the GLP-1 and GIP combination pills, which have some exciting data. And those are going to be in phase 3 trials, I believe. So I think that there are potentially some other drugs on the horizon that may be more promising than semaglutide, but I think there's still more that needs to be studied. So now I'm going to conclude with just a few, just briefly touching on a few studies that I thought were interesting. So first is another study looking at MASLD. So this is NAFLD and advanced fibrosis are common in adults with HIV and associated with unique histology. So this was a study that was a prospective study that had about 108 participants with and without HIV who had both FibroScan and then they had liver biopsies. And what they found was that MASLD prevalence was high, so it was 53% in people with HIV and was associated with typical metabolic risk factors. That prevalence is consistent with what's been published in previous data. But I thought was really interesting was that the fibrosis on histology was less pronounced in people with HIV, but then the fibrosis stage was higher in people with HIV, which may suggest that there's some distinct mechanism that's driving MASLD in this population. And I think it's something that's worth keeping in mind also as we think about using these drugs for MASLD treatment. The second abstract that I'd like to talk about was looking at prostate cancer. So this was looking at prostate cancer characteristics and outcomes, and this was in the VAX study. So they were looking at people with and without HIV in this veterans cohort. And they found that, interestingly, HIV infection was associated with higher PSAs in people who had prostate cancer, and that PSA testing was overall less frequent among the people with HIV. They also found that people with HIV were more likely to have higher risk or advanced prostate cancer when it was diagnosed, even after adjustment for age when compared to the people without HIV. I think it's hard to know what to do with these findings and that it doesn't answer the question about PSA for prostate cancer screening in people with HIV. But I think my takeaway from this is just having a higher threshold to really investigate when my patients have prostate-related symptoms. I would be remiss, given my mentor, to not talk about the lung function study that was presented. So there was a study that was based out of the live cohort, and it was looking at lung function outcomes and mortality. And what they found was that this one lung function metric, the forced expiratory volume in 1 second, or the FEV1, which is part of routine PFTs, was associated with lower all-cause mortality and HIV-related mortality. So having an improvement in this lung function metric was associated with lower mortality. It's interesting. I think it's hard to make any kind of generalizations about these findings. There have been other studies in the general population looking at non-obstructive lung diseases and having impairments in FEV1, and there have been some associations with mortality. but it's unclear if this is a true marker of mortality or if it's just associated with other hidden confounders. And I think also history of prior pneumonia, which can decrease FEV1 and FVC, also may be playing a role here. And then the last abstract that I'd like to talk about was weight change after starting doravirine after ART experienced individuals. This was based out of an observational cohort, the OPERA cohort, and people who were switched to doravirine. And what they found was that doravirine was associated with weight loss in the absence of TDF or efavirenz, but then they had a variety of subgroups and did a subgroup analyses, and they found that actually the highest amount of weight loss was being in those who were on TDF or efavirenz after switch, and that weight loss was small or null if on TDF and or efavirenz before and after switch. So it does seem like doravirine may have some small effect on weight, but it also seems like TDF and efavirenz were playing a role in some of their findings. So in conclusion, comorbidities are becoming an increasing focus at CROI for good reason, but HIV-specific treatments and strategies are lacking. More studies are required to understand the mechanisms that underlie comorbidity development. So I know we have a lot of investigators in this room, so thank you for all the work that you're doing. And if you're interested in doing this work, please look into it. I think I'm biased, but I think we need to include more women in many of these studies. And then Dr. Havler had a great point that we need to strike a balance between the absence of having HIV-specific data while keeping in line with the latest medical innovations and trying to be as innovative as we can. So with that, thank you. And I'll take questions, I think, or I can wait till the end. Okay.
Dr. Abelman, I see him. Or do you know that was just a... You can also think on it.
If others come up, I can answer at the end as well.
That's great.
Thank you.
Great. Thanks.
Hey, everybody. So for those of you who I don't know, I'm Michael Peluso. I'm a cure researcher here. And I'm going to try to provide a sort of overview of the implications of some of the exciting cure research that was presented at CROI this year. A lot of this stuff is sort of far away from the clinical setting, but we are very excited about some of the findings that that were presented at CROI, and some of that will help kind of inform the next round of cure-based research studies that we do here at UCSF, and that will be happening all around the world. I have some disclosures on the bottom of the slide. So here's the outline for my talk. I'm going to present just a couple of studies that I thought were really interesting on the HIV reservoir, which is sort of the foundation upon which cure research is built. One in particular, looking at sex differences in the reservoir that I thought was really provocative. I'll talk about how little virus it takes for rebound to happen. Some of the really interesting immunotherapy studies that I think are gonna, like I said, inform the next round of cure-related clinical trials. Some really exciting mechanistic work in interpreting the prior round of HIV cure trials, particularly related to broadly neutralizing antibodies or BNAbs. And then I'll show a study, sorry, a monkey study that I think is going to be an inspiration for some of our upcoming work at UCSF. So I'll begin by discussing some interesting work about sex and the reservoir. So based on prior work by Eileen Scully and Monica Gandhi and others, we know that women mount a more effective immune response to HIV infection. And this is manifest in several ways. Women in general have lower viral load set points than men. They're also more likely than men to achieve undetectable viral loads without HIV meds. The two, quote, natural cures of HIV infection to date, which are called exceptional controllers, the San Francisco patient that Steve and I and others have described, and the Esperanza patient from South America, are both women. And we know that in general, HIV expression during ART is lower in women than men. So this was a really cool study. We were involved in this study. It was a collaboration between us here at Scope, Phyllis Tian's group and the WISE cohort, and the Reagan Institute at Harvard, where we applied sort of the new generation of HIV reservoir measurement technologies in a cohort where we deliberately recruited women living with HIV to ensure that at least half the cohort were women. And the findings were really quite interesting. So the first thing we were able to look at was the characteristics of the reservoir in terms of whether it was intact, replication competent, or defective, which is the majority of the reservoir. And we actually found no differences based on sex in terms of either the intact or the defective reservoir. But when we did a deeper dive into the various characteristics of the reservoir, it was super interesting. And so this is the high-level finding from the study, which is that if you look at the top, you can see the geography of the reservoir, where it is located in the chromosomes. And in women, there is a much higher concentration of the reservoir in these blue areas, which are non-genic areas of the chromosome that are not transcribed. They're basically gene deserts. Nothing happens there. And that was in comparison to men on the left, where you can see a higher proportion of the intact genomes were in active regions of the chromosome. So this is a really, really interesting observation. And what's particularly cool about this is that this is more pronounced the longer that people are on ART. And this is the exact same pattern that we see in these two cases of natural cure, these exceptional controllers, where the reservoir is really concentrated in these non-genic regions. So to me, this emphasizes sort of 2 points. A, that there are important biological differences in the reservoir between women and men. And that's really important to understand. We don't know why that is yet. And B, it's so important for cis women in particular to be in cure trials, because they are the ones that, in terms of their reservoir, look most set up for, quote, cure. So I thought that was, I was super excited about that study. They were not able to find a mechanism by which that sequestration happened, but there are differences in immune responses in general between women and men. And this is sort of the next layer of what will happen to try to understand that. The other reservoir study I wanted to mention was this work from Matthias Lichterfeld's group at the Reagan, where they were looking at the results of this study called RIVER, which was a therapeutic vaccine study in people with early HIV infection. I won't go into the details of the clinical trial, but what was really interesting was that although the vaccine-induced T-cell response did not have any effect on reservoir measurements over time, they were able to look at the reservoir sort of cells that were harboring intact viruses and characterize those cells. And what they found was that those cells had a lot of markers upregulated that suggested that they were able in early infection to evade the innate immune response. So we talk so much about adaptive immunity and CD8 T cells and in HIV, but we don't really talk as much about the innate immune system. And I think that this story is part of a sort of growing number of stories suggesting that we probably have to be paying equal attention to the innate immune system and potentially manipulating the innate immune system as we try to do the adaptive immune system in our clinical trials. Okay, so the next study I'll present, I've called It Only Takes One Virus. So there's a large amount of literature of these potential cure cases, the Mississippi baby, Tim Henrich's cases from when he was at Harvard of people who got bone marrow transplants, and Hiroyu's work here looking at very, very early treated HIV infection. And all of these people ended up rebounding despite having small reservoirs. And this was a study presented by Deborah Prasad looking at basically an effort to replicate what they observed with the Mississippi baby 10 years ago. So if you remember, I think CROI 2013 or 2014, they presented the case of this baby with in utero HIV infection who was begun on ART very, very early, within hours of being born, and suppressed, had no HIV detected. And when they withdrew ART, the baby eventually rebounded after, I think, 2 years. And so they were looking basically in this study to sort of do a proof of concept to replicate this finding and show that it could be repeated. And so what they did in order to do this is they recruited dozens of newborns who had confirmed in utero HIV transmission, but began ART within 2 days after being born. And then they characterized these babies/children with a variety of different measurements to try to figure out who was most likely to be, quote, cured of their HIV infection. I won't get into all of these parameters, but of the 54 potential candidates, they identified 6 who had this series of parameters that suggested extremely, extremely small reservoirs. So no detectable HIV antibodies or antigens on like 4th-gen testing, and they did reservoir measurements and basically didn't find anything. They had intended to interrupt ART when these babies were 2 years old, but because of COVID, it was delayed by 3 years. And so ultimately, the children interrupted ART when they were about 5. So they identified these 6 children from 4 or 5 countries here who, as you can see, began ART at 1 or 2 days of life, and then were interrupting ART between 5 and 6 years old after being on continuous ART for 5 years. And what they found was absolutely fascinating. So 2 of the children, when ART was withdrawn, ended up having viral rebound within 2 to 3 months. And you can see that in E and F here. And then the remaining 4 children went at least a year with nothing detected. But one of them, who got out to 2 years, had rebound after 2 years, which is basically exactly what happened with the Mississippi baby. And so they were able to effectively replicate that observation. But what this says to me is, wow, it's hard to imagine a smaller reservoir than what these children had. And that very, very tiny reservoir was still enough. And so that suggests that basically all of our cure strategies are going to need backup plans, because this can happen even after years. So I'm going to shift now and talk about some of the exciting immunotherapy studies. And as you all know, our group here is really engaged in HIV cure-related immunotherapy, and there's a lot of really exciting stuff presented this year at CROI. So this is work from our colleagues at OHSU, who run a monkey colony where they're able to do really novel HIV cure-related research that then Steve and I try to translate into people. And so this was a study of SIV mRNA vaccine with a lipid nanoparticle vector. We're all familiar with lipid nanoparticles now from the last 4 years. And basically what they did in this study was the monkeys got SIV, they were treated at day 9 of their infection, and then they received this therapeutic vaccine at baseline, 3 weeks, 6 weeks, 20 weeks, and about a year. And then 2 weeks after the final dose of the vaccine, ART was interrupted, and there was a placebo group in this study. And I think what's really exciting about this study is we often talk about vaccines not doing much or not working. And they actually saw a pretty striking effect here, where the time to virus rebound was extended by about 2 weeks in the group of monkeys that got the therapeutic vaccine. The peak viral load after rebound was about 2 logs lower, which is very exciting in the group that got the vaccine. And then if you look at the overall rebound curves with the placebo group in green and the intervention group in blue, there's a clear difference between those curves, particularly in the first 6 to 9 weeks of rebound, with a difference in the area under the curves. So this suggests that they were really able to move the needle with the vaccine, and that we think that blunting in people the peak and altering sort of the slope of rebound is really, really important in determining whether someone will be destined to control HIV. And so this suggests that we shouldn't give up on including vaccines as part of that strategy yet. So this was a really, really interesting study of a checkpoint inhibitor, which I am not going to try to pronounce because I tried it 3 times yesterday and was unable to not embarrass myself. But it is written there and it starts with a B. And this was, so this was a study in people. And what they did was they did a first stage of the study where they gave individuals on ART this checkpoint inhibitor and then interrupted therapy. And that didn't really have an effect, so I'm not going to talk too much about that. But stage 2 of the study was quite interesting. And so what they did in this study was they interrupted ART, and then at 0, 2, 4, and 6 weeks, every 2 weeks during the initial treatment interruption, they administered a dose of this checkpoint inhibitor to see what would happen. And so just as a reminder for checkpoint inhibitors, they basically address this issue of sort of cellular immune exhaustion and open up those cells that are kind of getting tired out to target whatever antigen that they're supposed to go after. And so the idea, with the rationale for this study was to basically prime the immune system during this critical period in the first months after ART wanes to be able to really respond well to the virus. And so what they found was really fascinating, which is that in the individuals who got the checkpoint inhibitor starting with the treatment interruption, 6 of the 9 individuals that they reported were able to achieve some level of partial HIV control during the treatment interruption. The proportion of 6 out of 9 in a HIV cure study is extremely high. The only other study that has achieved that proportion is this combination trial that we did a couple of years ago, which I'll talk about later. So a really provocative finding that suggests that manipulating immune system checkpoints during treatment interruption can move the needle on people's ability to subsequently control. They did an initial round of mechanistic studies to understand, especially these 2 individuals that you can see on the bottom here who had years of control with viral loads around 100. And they found 2 things. As expected, CD8 T cells were more activated and less exhausted. But really interestingly in this study, in the group that got the checkpoint inhibitor, they found that there were markers on the CD8 T cells that suggested that those cells were primed to hone to lymph nodes, particularly to the B cell follicles in lymph nodes. And we think that B cell follicles within lymph nodes are sort of an important sanctuary site for HIV. So the idea that this was able to potentially have an effect by targeting the immune system toward that sanctuary site suggests that future iterations of studies like this that can improve B cell follicle honing of CD8 specific, HIV specific CD8 T cells could be beneficial. So they are now planning another follow-up study to kind of build upon these findings. But I think, checkpoint inhibitors are really complicated and the safety profile is somewhat worrisome sometimes. I think the key thing in this study is that they used very low doses and that overall their assessment was that the safety profile was good. There were no serious adverse events. There were a couple of sort of grade 1, grade 2 events that resolved. But it's an exciting sort of new weapon in our armamentarium for HIV cure. And we are involved with a similar checkpoint inhibitor study that Sharon Lewin's group in Australia is doing. I'm really excited about this study. Very, very interesting. So one of the sort of other types of immune therapies that there's a lot of interest in now are cytokine therapies, things like interleukins that we can give therapeutically. And so this was a study of monkeys in which there were 4 groups that received either placebo or different cytokines at 2 time points. And so what they did was they administered a combination of IL-12 and or IL-15 in these monkeys who had SIV at the time that they were beginning ART. So that's the first set of arrows here. And then once they were suppressed on ART, about 6 months later, they gave another round of these same treatments. And then a few weeks after that, they interrupted ART in all of the monkeys. And what they found was quite provocative, which was that the group that got IL-15 treatment, which is shown here in green, had a similar time to rebound, but a really remarkably reduced viral load peak and viral load set point between 2 and 3 logs, which is a big effect. And they were able to look mechanistically at what happened in these monkeys. And what they found, again, was that there was, more cytotoxic T cells that were that were primed to home to the lymph node follicle. So a similar finding from the checkpoint inhibitor study, now with the cytokine study, the similar mechanism of control in both studies. This is exciting because there is clinical grade product that is IL-15 agonist that has been used in humans, that is approved now, I believe, for some cancers, and has already been studied in the context of HIV. So as like a good track record and a known safety profile in people. And so this suggests that this type of treatment timed appropriately could really move the needle on our cure agenda. And so Steve and Rachel and I are actually working on a proposal right now that will aim to translate basically this study into a phase 2 pilot in people. Okay, my next section is about broadly neutralizing antibodies. So there's been a lot of talk about broadly neutralizing antibodies over the last few years. There's a beautiful review that Hyman, Scott, and Steve Deeks wrote last year on the potential for broadly neutralizing antibodies across prevention, treatment, and cure. And there's a lot of interest in broadly neutralizing antibodies as a component of cure strategies. So the first study I'll present that got a lot of attention, was also part of the CROI press conference this year, was work by Boris Yulg and his team, where they looked at a combination of broadly neutralizing antibodies, which are listed at the top of the slide. And one of these in particular, VRC07-523LS, is one that we have a lot of experience with, and is modified and is a long-acting broadly neutralizing antibody that has a very long half-life. The others have respectable half-lives, but not quite as long as VRC07. And so what they did in this study was they took participants who were living with HIV on ART, who were undergoing treatment interruptions. And at the time of the interruption, they administered this combination of broadly neutralizing antibodies every month for 6 doses, which you can see here on the left. There are those kind of 6 peaks, and those are the different doses of the antibodies. And then they watched how they waned over time. And then they looked at what happened in terms of virus rebound, because these people were then off of ART. And they found that 2 of the individuals rebounded quite early. That's not shown here. And those individuals, their rebound virus had resistance to the bNAbs, so that's not surprising. There were 5 individuals who rebounded a few weeks after the final dose. So there were low levels of broadly neutralizing antibodies on board still, but resistance was not the mechanism. It was probably just waning antiviral effect. But really interestingly, there were 4 individuals who remained suppressed basically through 1 year of the study. And this is basically 4 more individuals adding to this growing list of people with durable post-bNAb control. a caveat here is if you look carefully at one of these individuals shown on the right, the viral load is in red at the bottom, and the BNAb levels are in those different colors coming down. You'll see that the level of VRC07 523 is low, but it's not zero. And so it's sort of right at that threshold where we think that a BNAb can still have an antiviral effect. So it'll be interesting to see what happens over a longer period of time in these individuals. One of the really tricky things about BNAb studies and cure research is we don't know what the threshold is at which the antiviral effect totally goes away. And so there are skeptics out there who will say there can always be at least some residual antibody that's having antiviral effects, and it's impossible to know. And that might be true, but we're trying to figure out how to interpret these levels. So I'm going to transition now and talk about some really interesting mechanistic biology that's been done to understand some of the really interesting results that have come out of the prior wave of cure studies. And I'm excited about this because our program was involved in a number of these studies. So many of you may be aware that over the last 4 years, with a grant from Lily Cohn, we've been doing this highly monitored treatment interruption study in scope, and many of your patients are involved with this protocol. And so what we do in this study is we take people who are healthy and on stable ART. We do a bunch of baseline measurements while they are on ART to establish their sort of personal baseline for a variety of different markers. And then we do a highly, highly monitored treatment interruption where we basically see people 3 times a week until their virus reemerges. And we bank tons of samples with the goal of capturing that exact moment when the virus and the host immune system re-encounter each other for the first time off of ART. And then as soon as their viral load is above 200, which is quite low, we resume ART. So we don't think there are any long-term consequences from this. So what we see in that study is a huge amount of variability in what happens to people in terms of their virus coming back. So time in days is on the x-axis here, and the viral load is on the y-axis. And you can see some people on the left side of this graph in red rebound as you would expect within 10 to 20 days after being off of ART. But there are a number of people who take 3 weeks, 4 weeks for the virus to come back. And then there are some people who end up spontaneously controlling the virus without resuming ART, kind of shown on the farther right side of this graph, either at viral loads less than 1,000, so kind of viremic controllers, or we have one sort of full elite controller who rebounds and then spontaneously controls. So there's a lot of variability in this study, which gives us a lot of power to understand biologically what's happening. So our collaborators in the Silicano lab at Hopkins did this really neat study focused on ANAB. So we talk a lot about BNABs, broadly neutralizing antibodies, but we don't talk that much about ANABs, which are autologous neutralizing antibodies. And these are natural neutralizing antibodies that are not generated in the lab, but are part of a person's normal immune response to HIV. And what happens in the course of an untreated infection is that the ANABs almost always lag behind the evolution of the virus. And so they're never able to control the virus. But we don't know if they're biologically important. And so what they did in this study was they basically looked at the time to rebound in those graphs that I just showed you. And then they looked at the reservoir viruses in those people to see how well those people's own plasma could neutralize the viruses in their reservoir. And what they found was this really striking, very strong direct relationship between the potency and kind of the coverage of the autologous neutralizing antibodies and the time to rebound, where people who had more potent and better coverage of ANABs for their existing reservoir variants had a longer time to rebound, suggesting that these actually might have a biological effect. And that if we can kind of rev these up, it might be an important component of cure strategies. There was a second totally unrelated presentation on this topic that completely replicated the findings in the context of a cure intervention study. So I won't go into all of the details of the study, but it was a really nice presentation by Katie Barr looking at the importance of ANABs in a trial of BNABs. And what her group found was that the reservoir susceptibility to the intervention in the study, to the BNABs, did not matter in terms of predicting time to rebound. But what did matter was the reservoir susceptibility to those participants' own ANABs. And the graph looks like it's going in the opposite direction, but it's because one of the axes is inverted. And so they, in this cure study, identified the exact same relationship that the Silicano group identified in this observational study, suggesting that measuring ANABs in cure studies is going to be really important for interpreting the results of those studies. Okay. And then there was also a lot of attention on the cellular arm of the immune system in clinical trials. And a lot of this work was led by Rachel Rudishauser, who's here, as well as Demi Sandel, who's a graduate student in Rachel's lab. And so they studied samples from our local treatment interruption study, the observational study where we take people off of ART. And they looked at these people who were destined to rebound quickly versus those who were destined to control. And they looked really in the first couple of weeks off of ART. And what they found was that there was this really striking relationship where the individuals who went on to spontaneously control infection had really dramatically higher increases in the expansion of T cells during that critical time period. So those who went on to control had more proliferation of HIV-specific T cells after they were off of ART during this rebound period, suggesting that that's an important marker of going on to control. And so they then applied these same measurements to this combination immunotherapy trial that Steve and I have done over the last few years. So I won't get into all of the details of the trial because, as you can see, it is quite complicated and we're all still recovering from it. But it was a variety of different interventions, including a therapeutic vaccine, which I talked about at the beginning, a toll-like receptor agonist, broadly neutralizing antibodies, which I mentioned, and then a long treatment interruption. And what was really exciting about this study, the study of 10 people performed during COVID, was that 7 of the 10 individuals in this study went on to control HIV at viral loads around 1,000 copies or less for 6 months to a year after their virus came back, which is, as I mentioned before, a really high proportion. You would expect maybe 10% of people to do this. And so we presented the clinical outcomes at CROI last year and have been trying for the last year to figure out why this happened. And Demi and Rachel basically have provided a mechanism now where they similarly identified this dramatic proliferation of HIV-specific CD8 T cells during this early rebound period that clearly distinguished, as you can see on the left in blue, the people who went on to control with low set points from the people who rebounded quickly in red. And so you can see this longitudinally on the first graph. You can see it cross-sectionally on the second graph where the blues are higher. And then there's also a clear relationship on the third graph between the viral load set point and the proportion of proliferating CD8 T cells. So we're very excited about this because it provides an explanation for what we saw clinically in that study. And just to say, this is a known phenomenon in other cases of spontaneous HIV control. So there is a very clear story emerging here that this is an important biological outcome to target in our cure work. And then the last study I'll present is all around this concept of a one-shot cure, which I think is where we need to get to with our HIV cure work. We need sort of a shot in the arm that'll work for everyone. And so this is another monkey study that I think is important proof of principle. So they injected an adenovirus vector that would express the material to generate two broadly neutralizing antibodies. They injected this into skeletal muscle, which is quite stable, of these macaques who were on ART, and then they interrupted ART. And by far the most important finding in this study is what is in green and yellow, which is that these macaques had really good expression of these antibodies that were being generated continuously over a 2-year period at quite remarkable and stable levels. And basically the majority of the monkeys that got the injection, suggesting that this is a really exciting strategy to have people sort of naturally, after a vaccine, have ongoing production of these broadly neutralizing antibodies, so they wouldn't need to come in for monthly or 6-monthly infusions. They actually found that a substantial proportion of the macaques were able to, in concert with this expression of the broadly neutralizing antibodies, keep their SIV suppressed for I think 6 months to a year. And so there's a lot of excitement about this finding and a lot of desire to translate this into people. And we are working with Alex Ballas at the Raygon and just submitted an ACTG proposal this week to try to replicate this in people, looking at adenovirus vector with a BNAb to see if we can get sustained levels in people through a variety of kind of combination strategies. So this is what I presented, some exciting work about the reservoir, progress on many fronts in immunotherapy, a lot of which I think we will see translated into clinical trials over the next few years, including checkpoint inhibitors and cytokines like IL-15. Really cool mechanistic work led by people at UCSF, understanding mechanisms of control in the last round of HIV cure studies, and also progress to the ultimate goal, which is a one-shot cure that, in theory, could also prevent reinfection. So I will end there and just say again, this CROI was spectacular, but it was especially special for me because this was the first time that I had people that I sort of mentor attending CROI presenting stuff. And that was so cool. Like I remember CROI 10 years ago, the first time I went and had a poster, and it like totally changed my life, and I wouldn't be here if not for that experience. So it was just amazing, aside from the science, to just see that happen and to kind of see that in people that I now oversee. So thank you to the organizers for that. I will end there and happy to take questions if there are any.
Thank you, Dr. Giselle. That was a beautiful note to end on. No questions from online. Any questions from the audience? I know Dr. Havlier and I have one. And this can be for either Dr. Abelman or Peluso. That was terrific from both of you. Really enjoyed it. I'm not sure if this is on, but I'll project. I have 2 questions for you, Michael, which is one, what do you there's a recent paper out about cemiplimab, one of the other PD-1 inhibitors in HIV, showing that, they had to stop the study early because 4 out of 4 had side effects, and just makes one nervous. And it might be that HIV, folks living with HIV have more of a reaction. And I want to hear your thoughts on that. But the second one is, and forgive me as the non-immunologist, but when I think about vaccines that trigger antibodies, that's not what it usually looks like. And that's so fascinating to see that level. What is different about that adenovirus vector? Usually you trigger this and then it comes down, but the immune system is able to remember the exposure, not provide this stable. So yeah, I'm probably missing something, but help me understand how it does that, because that's very, very exciting.
Yeah, so the first point, I think, there's a lot of caution needs to be taken with checkpoint inhibitors. The context in which we are giving these for HIV cure is totally different from the context in which they were developed, which is for cancer, where, people had much higher mortality, and the sort of risk benefit calculation is totally different in sort of advanced cancer than well-controlled HIV. I think a lot of it is going to depend on the dosing. I don't know what the dosing was in that other study that you mentioned. The proponents of checkpoint inhibitors argue that lower doses are likely to have less of a bad side effect profile, which intuitively makes sense, but I think we need to see that. People are enthusiastic about participating in these studies, but you really have to counsel people about the risk for sort of these immunologic events, lots of thyroiditis and things like that. So, yeah, and then the second point is that, so I am not an expert on the vectors, but, there's some concern with other AAV vectors. In general, these are exciting because they're quite stable. They're injected into muscles that have, or the cells have long half-lives, and they produce genetic material that is sustained, unlike a lot of the others that like wane. As a result of that, in theory, as long as the muscle cell is still alive and the genetic material is still there, it will continue to produce more of the protein. And so the main challenge with all of these studies, especially in people, is the generation of anti-drug antibodies, ADA, where because these are not sort of human materials, the immune system in some cases generates antibodies that clear the antibodies that you want there, you want to stick around. And that's been the main limitation in people so far. Seems to happen in like a third or more of people. These vectored BNAb studies in people to date have had good safety, but have been really limited by the ADA, and people just can't kind of achieve those remarkably high and sustained doses. But there are strategies that have suggested that we can get around this, either by splitting the dose in different muscle areas, or by giving sort of a short burst of steroids at the time of the injection. And that sort of blunts this ADA response and may allow sustained levels. So a lot of work still to be done on this. And the biology is complicated, but I think as of right now, in terms of the philosophy of a one-shot cure, that is a lot more scalable than 34 weeks of immune therapy with infusions and electroporations and whatever. So hopefully we'll be able to kind of move the needle on that over the next 10 years.
Thank you so much. I see that there were maybe one or two other questions. We're over time, so we'll pause for now, but please come join us at the front if you have additional questions. Thank you. Thank you to both of you.
Thanks, everybody.